今ど。I am Toshio Matsushima from Japan, one of the Dr. Orton's fellows. Today's title is The Evolution of the Cerebromedullary Fissure Opening, Its Effect on Post-Fossa Surgery from the Fourth Ventricle to the Brainstem. I am going to talk about the surgical anatomy of the cerebromedullary fissure and the trans-cerebromedullary fissure approach, also called Taylor-Bellow approach, with historical review. I had a cerebromedullary fissure is the only entrance to the fourth ventricle without incision of the neural tissues. The fissure is furthermore separated into two, the uvulotonsillar and medullotonsillar spaces. The right row figures shows the opening of the cerebromedullary fissure, which is a trans-cerebromedullary fissure approach. I had opportunities to study the anatomy of the post-fossa under Professor Orton from 1980 to 1982. When I performed the project of the fourth ventricle, I learned the anatomy of the cerebromedullary fissure. The fourth ventricle is a cavity sandwiched with the brainstem and the cerebellum. Then there is a three cerebellar brainstem fissures: the cerebral mesencephalic fissure, cerebral pontine fissure, and cerebromedullary fissure. The cerebromedullary fissure is the biggest of the three fissures. I dissected the fissure and learned the actual anatomy of the cerebromedullary fissure in detail. This slide shows a step-by-step dissection of the subocular surface. The cerebromedullary fissure is hidden by the subocular cerebral surface. The left tonsil and the part of the biventral lobule are being removed. Then we can see the cerebromedullary fissure. The floor of the fissure is the roof of the fourth ventricle, which is composed of the inferior medullary velum and the terra choroidea. I'll show you dissection of the cerebromedullary fissure using the cadaveric specimen.
Now we are entering the right cerebromedullary fissure. The fibrous connective tissue between the tonsil and the terra choroidea is being cut. In the bottom of the fissure, a part of the lateral recess can be seen. The biventral lobule is being cut. After removal of the most inferior portion of the biventral lobule, the right lateral recess and the flotulus appear. The posterior wall of the lateral recess is the thick membrane called rhomboid lip. The anterior wall is the flotulus and the roof is the terra choroidea with the choroid plexus. The 9th and the 10th cranial nerves are situated anteriorly to the lateral recess. Here is the foramen of Lucica. Next, the tonsil is removed. As you can see, the tonsil is attached at only one part. It is connected with the white matter of the cerebellum at the anterolateral portion. Now, the supratonsillar space appears anteriorly to the right tonsil. The semi-translucent membrane is the inferior medullary veil. The tonsil is attached at the anterolateral portion. Now the flora of the right cerebromedullary fissure is entirely seen. The anterior half of the flora is the inferior medullary veil, and the posterior half is the terra choroidea. The choroid plexus can be seen through the terra choroidea. The terra choroidea laterally extends to form the roof of the lateral recess. The boundary between the inferior mesoibium and the telachoroidea, which we can call telovelar junction, is easily detached. When the telachoroidea is reflected, the choroid plexus attached to the telachoroidea appears. Let us look at the lateral part of the fissure. This is the most lateral portion of the lateral recess. The foramen of Ruschka can be seen, and its flora is made of the rhomboid lip. The 9th and the 10th cranial nerves are situated just anteriorly to the foramen.
To my knowledge, Dr. Yunpeng Huang, neuroradiologist, is the first person who reported the anatomy of the fissure in detail. He published his paper on the veins of the lateral recess in 1967. Around the 1960s, he studied the fissure to reveal the cause of the vein of the lateral recess. In those days, there were neither CT scan nor MRI. The angiography was the only tool for the radiological diagnosis. After returning to Japan in 1982, I started the forced ventricular surgeries. At the beginning, I utilized the transvermian approach, which was a standard conventional surgical approach in those days. These illustrations show the transvermian approach from the old famous textbook, Kempe's book. The approach required the inferior vermis to be incised, and the vermian splitting syndrome often occurred post-operatively. In 1990, I encountered an unforgettable case of the ependymoma. This case taught me a lot. The tumor occupies the entire fourth ventricle and extended inferiorly to the level of C2. In the first surgery, I utilized the transvermian approach. I believed I could remove the tumor totally. However, the tumor recurred in the left lateral recess 1 year after the first surgery. I operated again and removed the tumor from the left lateral recess. From this case, I learned that I should have observed the lateral margin of the fourth ventricular tumor. That means observation of the lateral recess. After this beta experience, I started to dissect the cerebromedullary fissure sufficiently to remove the fourth ventricular tumor completely without leaving the tumor in the lateral recess. Opening of the fissure was very useful for the fourth ventricular surgery, like the opening of the Sylvian fissure in the trans-Sylvian approach. This was the beginning of the transcerebromedullary fissure approach. Around the time, we had MRI. I studied the cerebromedullary fissure anatomy on MRI and reported the first paper on the transcerebromedullary fissure approach in 1992. In the paper, I reported the MRI anatomy of the fissure and the representative tumor cases in which the tumor was removed through the transcerebromedullary fissure approach. In the right row figures, you can see the case of a capilloma in the pons. The transvermian approach requires the incision of the inferior vermis. The incision of the vermis and the lateral retraction of the dentate nuclei have sometimes been implicated in the so-called cerebellar mutism syndrome. After starting the cerebromedullary fissure opening, we did not have any cases in which the vermian splitting syndrome occurred post-operatively. In 1997, Kellogg et al. Reported that the cerebromedullary fissure approach did not cause post-operative vermian splitting syndrome, with good surgical result of their 11 cases. In 2000, Musi and Dr. Lawton presented the beautiful cadaveric demonstration of the fourth ventricular exposure through the cerebromedullary fissure opening. They called it a Terobero approach. This report made a significant contribution to the spread of this approach to the world. Next year, in 2001, we reported the medial type of the approach with the three different opening types: extensive, lateral, and lateral recess type. Based on our surgical experience of the 19 cases, each opening type should be utilized appropriately depending on which part of the fourth ventricle has been exposed. For the past 30 years, I have utilized the opening of the cerebromedullary fissure for various kinds of the region in or around the fourth ventricle and developed the transcerebromedullary fissure approach. The approach has mainly two routes, medial and lateral route. Since tumor in the fourth ventricle extend inferiorly and laterally through the cerebromedullary fissure, we can approach the ventricle not only from the medial side, but also from the lateral side. First, I will explain the medial route. The medial route means a transcerebromedullary fissure approach from the midline after midline subocular craniotomy. This approach became popular as Terobero approach after introduction by Dr. Musse and Dr. Lawton. I will explain the medial route, especially the extensive type. Procedure of the extensive type include first, dissection of the fissures around the tonsil. Second, incision of the terra-choroidea, especially the tinea, from the foramen majandi to the foramen brusca to open the roof of the lateral recess. The incisional line is indicated by blue and red arrows. Third, retraction of the tonsil in the superolateral direction. Fourth, same procedure on the contralateral side. To perform this approach, the inferior margin of the tonsil should be exposed. Sometimes partial C1 laminectomy is required. I'll show you how to open the fissure using the video. The case is cavernoma in the pons. CT scan shows the hemorrhage in the pons. Wide subocular craniotomy was done. Bilateral tonsil and the left PICA. The right tonsil is being lifted up and the right middle tonsil space is being opened. Now, we can see the interior of the fourth ventricle, foramen majandi, and the terra-choroidea. The tinea is being incised from the foramen majandi to the ventricular entrance of the lateral recess. There is a stray medullaris. The lateral recess is opened, and then the interior of the lateral recess is further exposed. Thanks to the opening of the fissure, the floor of the fourth ventricle is widely exposed. Now checking the facial curricula. There was a bulging in the suprafacial triangle. We puncture the bulging and remove the cavernoma. I'll show you the removal of the tumor through the medial route. The case is of ependymoma. Enhanced MRI shows the inferior and left lateral extension of the tumor. A tumor extends inferiorly between the tonsils like the tongue. Under the tumor, the caudal loop of the PICA is found. First, this extraventricular tumor has been resected. The area surrounding the obex, large left vein of the inferior cerebral peduncle is present. The tumor is being dissected from the fourth ventricle floor, the medulla oblongata. The dissection is done very carefully. A yellowish thin tissue is left to the floor. The right tinea is being followed to the ventricular entrance of the right lateral recess. The right lateral recess is occupied with a tumor. The lateral recess has been opened, and the right lateral margin of the tumor was confirmed. The tumor originates from the right lateral wall of the ventricle. When the originating portion is incised, a large ventricular tumor is able to be pulled out. After removal of the tumor, the entire outflow and dilated cerebral aqueduct are seen. However, the operation is not finished yet. Last, we are checking the left lateral recess. The tumor is still present in the left lateral recess. The tumor in the left lateral recess is being removed. Now the tumor removal is completed. The post-operative MRI revealed total removal of tumor. The patient has been doing well without any neural deficit. Next, the lateral route. The lateral route means the transcerebral medullary fissure approach from the lateral side after the lateral foramen magnum approach. This is a case of choroid flex papilloma originating from the right lateral recess. The tumor was located in the right cerebellomedullary cistern and right cerebellomedullary fissure, mainly in the lateral recess. It was removed through the lateral route of transcerebellomedullary fissure approach, combined with the transcondylar fossa approach. Through the lateral foramen magnum approach, a mass was exposed in the right cerebellomedullary cistern. It compressed the medulla oblongata medially and the tonsil and bimedullary lobule superiorly. Gradual opening of the cerebellomedullary fissure revealed that tumor was partially located in the fourth ventricle, and it was of choroid flex papilloma originating from the choroid flexus in the right lateral recess. After opening the right cerebellomedullary fissure, the tumor was subtotally removed. A small amount of the tumor tightly adherent to the ICA was left.
You have 2 minutes.
Okay, soon I'll finish. Dr. Abe is reported the usefulness of the unilateral transcerebellomedullary fissure approach for the OA-PICA bypass. Certain patients with aneurysm in the vertebral artery or PICA were treated using OA-PICA bypass after opening the cerebellomedullary fissure. We call the approach unilateral transcerebellomedullary fissure approach. Now I am using other variation of the transcerebellomedullary fissure approach. The illustration shows 4 different regions approached through the transcerebellomedullary fissure approach. In conclusion, anatomy of the cerebellomedullary fissure was demonstrated, and then how to use opening the fissure for the fourth ventricular surgery, that is the transcerebellomedullary fissure approach, was also explained. In the approach, the fourth ventricle and its surrounding area can be widely exposed without any incision of the neural tissue. I wrote on the transcerebellomedullary fissure approach and its variation in my textbook on the surgical anatomy and the surgery on the posterior fossa from Springer. Please take a look at the textbook. If you want to know about the transcerebellomedullary fissure approach, Dr. Lawton told us the combination of the knowledge of the microsurgical anatomy, use of the operating microscope has improved the technical performance of the many neurological procedures. Thank you very much for your attention. Sorry to a few minutes over.
Thank you for your presentation. You are just in time. Perfect.